We want to look at the olfactory system, which is that sense of smell. Sense of smell is the keenest sense that our infant has. We can definitely note that because of the simple reason of all the smells that we create in the environment and what type of response that our infant gives us from all of those, whether it come from an alcohol wipe or whether it come from a betadine or whether it comes just from the fact of the smell and so forth, you know, on our gloves and whatever is happening. So you have to remember that in utero he was smelling very positive things because of the simple reason that the amniotic sac, you know, was containing many of these receptors, and so, you know, he was bathed in that amniotic fluid, and so therefore established a keen sense of smell in utero. Smell and taste are linked. Our infants are highly responsive to odors. The most positive smell they have is their mom's. Now, you and I may not appreciate what mom smells like, but their infant will always know who they are and will always appreciate that. We also note that some negative smells we just mentioned: alcohol wipes, betadine wipes, chemicals, perfume, you know. So we need to realize that we have some things to overcome in the unit in order to create a unit that is more, I would guess, olfactory friendly. Remember, kangaroo care stimulates the olfactory system because they know their mom. They sense their mom, they smell their mom. It's a very positive experience for our infants. We also have to realize that there's some hazards, and some of those hazards are perfumes, some of them are medications. Remember the fact that we should sincerely look at going fragrance-free in our units. Many clinicians come to work, or many people that are coming in and out of our unit all the time, have on perfume. Some of them overcome us. Can you imagine what it's like for an infant inside an incubator that has humidity? Probably overwhelming for him. So therefore, maybe looking at going to a fragrance-free unit might be one of the things that you can put on your agenda to do, and that will be a positive influence on the olfactory system. Remember that alcohol, that betadine, the cleaning, you know, so forth, everything, you know, contributes, many things contribute to a negative environment as far as the olfactory system is concerned. And then, of course, you know, soaps and lotions that you and I use or that the hospital provides us possibly are scented. We need to take and look at unscented ones so that it doesn't overwhelm the infant. Again, encourage the staff and parents to avoid perfume, to avoid very, smelly or maybe over-perfumed soaps and lotions and so forth. And then also, you know, work with environmental services to do anything that they can in order to decrease the amount of obnoxious odors that come from the cleaning products that we have. Remember, when you're cleaning your incubators, always give them the opportunity to sort of dry out and to air out afterwards, and not, you know, put an infant directly in there afterwards, because sometimes we have a residual smell that lasts in there, and just by leaving a door open for a few hours can usually take that away. We want to look at the auditory system. That system is developing between 18 and 35 weeks. So when they get to us, that sense of hearing is present. You know, we know that the auditory system is fully functional, it's structurally complete, it continues to develop after the first year of life, and the fact that our infants come to us being very sensitive to impact noises, to loud noises, and that it can sometimes increase their blood pressure, which, you know, introduces the possibility that they will have IVH or germinal matrix bleed. We also realize that they're unable to differentiate, or that they're unable to habituate to sounds. You and I habituate. How many of us can listen to a pulse ox for several minutes, you know, and a little bit longer, and we never even hear that pulse ox? But that infant hears that pulse ox every time it goes off as if it is the first time that he has ever heard that pulse ox go off. You know, our infants have been hearing through amniotic fluid. They've not been hearing through air. So consequently, you know, the decibel level that we create in the unit significantly impacts them, and does bring about sudden changes in heart rate and in blood pressure. Apnea and bradycardia incidences increase. And of course, the louder our units are, or the louder that we have the decibel level in our unit, the more prone our infants are to having some sensory neural hearing loss prior to their discharge from our unit. When we take and look at auditory, we need to be very familiar with the OSHA guidelines, because the OSHA guidelines apply to us as adults as well as apply to our infants. We need to realize that increasing the decibel level in our unit can cause damage to our delicate auditory structures. Remember that our infants can exhibit hypoxia, they can exhibit increased blood pressure, they can have apnea and bradycardia, they can have increased intracranial pressure, all because of the noise levels that we have demonstrated in our unit. We know that the intrauterine environment is somewhere, less than 45, some 40 to 70 decibels, I believe, is some of the latest research that's been done. And then, of course, remember the decibel levels are through fluid, not air, and the fact that they are continuous and they're very rhythmic. So, this is the environment that our infant has been exposed to. And when he comes to us, our unit is totally different, okay? Because normally we're going to have decibel levels that are going to exceed 60 decibels and possibly go up as high as 80, 90, 120 decibels. The American Academy of Pediatrics, as it stands today, has made the recommendations of less than 50 decibels. And we know that they are looking at guidelines, I believe to be introduced in 2010, of an environment that is less than 45. We know that we have to look at equipment. We know that staff sometimes is the largest instigator of the increased noise levels in our units. We know that parents do contribute some, but parents sometimes can be our best monitors and everything, because they, are wanting a nice, calm, and quiet environment. And when we're looking at noise levels in our unit, we've got to look not only at the micro environment, but we've got to look at the macro as well, so that we take and that we make changes in both of those environments to have that conducive sound level that we need. This is a slide that's slightly old, but I still like it because of the simple reason that in utero, back in 1972, they were looking at the fact that we had intrauterine decibel levels of somewhere around 55 to about 85. We now know that we're looking at intrauterine sounds of about 40 to 70. And also the fact that if we take and look at the other slide that we have here, the NICU environment is 60 to 90 decibels, and actually it can peak at 120. So to change that, to get down to a decibel level of 45 and 50, we all have a lot of work to do. And granted, we're not going to get rid of all the spikes in our unit, but we're hoping that we will be able to exhibit an environment through maybe the acquisition of new equipment, maybe through the acquisition of remodeling, maybe we're building a new unit. So therefore we can incorporate many of the things that we would like to incorporate in a unit there, so that we do have the environment giving us a decibel level that is much more conducive. We also note, if you take and you look at this chart, sort of think it's self-explanatory. It came out of the American Academy of Pediatrics. I believe it was in 1993 or something, 97, somewhere along there. And the fact that it just gives us an idea of what noises our infants are exposed to in the unit, and the fact that just closing porthole doors can be painful to our infants because the decibel level is so high. So I think that we need to take heed as to what our everyday practices are and see how we're going to bring that decibel level down to that more conducive level. And then, of course, seems like, as many signs as we put up that say it's a quiet zone, and everything that we try to do to keep that noise level down, there is always someone that's truly, truly not on the same page that we're on. So, it's very difficult. And as this cartoon, indicates to us, even our security personnel are not on our side of the fence sometimes in the fact of keeping the noise level down. So we know that, the human factor is one of the greatest contributors to noise, and so therefore we truly have to work on that in many different avenues. We also know that when we're looking at our sound and our noise in our units, remember that in adults, if we're exposed to decibel levels greater than 80 decibels for greater than 8 hours or longer, that actually we can have some sensory neural hearing loss as well. So therefore it is important that we take and we look at what's happening in our NICU so that we do not create those same type of ills with our infant. Remember, hypoxia, increased intracranial pressure, increased blood pressure, increased apnea and bradycardic episodes are also things that we will take and we will have exhibited with our infants if we keep that noise level up. So, take heed, work on this. It truly is an evolutionary process in our unit in order to be able to create noise levels that are most appropriate for our infants. And we want to take, and we want to, you can work with your biomedical people. You can actually take and you can look, when you're discussing with vendors, when you're talking about new equipment, when you're talking about redesign and rebuilding, talk about the alarms on the equipment. Talk about what kind of acoustical tiles they have, what kind of acoustical floors they have. Always take and look at that. Take conversations away from the bedside. We don't need to give report over the bedside to our infants. Keep equipment, sort of away as far as we can so that we can decrease that immediate noise level. No syringe pumps inside the bed with our infants. Monitor some days, go to Radio Shack. You can buy a decibel meter and you can go around and you can sort of measure the decibels. There's some there's actually a unique system on the market today that actually is monitoring the noise level in our units that actually will help us to adjust our lighting in the nursery. Because remember, lights are up, noise levels usually go up. When lights go down, the noise level usually goes down as well. So there are a lot of options open to us today to really control that environment. Positive stimulus for our infants are that parent's voice. It's a nice, soothing, calming voice, and they relate to that. They know their mom's voice, and they know their dad's voice. So consequently, those are very positive for our infants, and we should allow them that opportunity for that interaction. We also know that, we've tried many things, and, some people say, well, we put covers over our beds. Well, covers are only to help to keep out the light. They do nothing for our babies as far as decreasing the noise level inside. So, they don't give us that. They do send us a positive message, though, in the fact, hey, there's someone very special growing inside this bed. So it should be, an indication that we need to be quiet, that we need to preserve this microenvironment for this infant and have it to be very positive. Auditory. Remember, we got to take care of that macro environment. Remember, we're going to move that conversation away from the bedside. We're going to try to do as much as we can to decrease that stimulation that's flowing over the top of the bed. A great a poster, I believe, and it's been shared by many, many people, and that is whisper while you work. Here are the dwarves, and everything, just giving us an indication that we need to be quieter while we're doing our work.